when we talk about surgery for metastatic renal cell carcinoma, and it's easy just to throw the word surgery around, but in this setting we're talking about just cytoreductive nephrectomy. Because we also know when we talk about surgery that patients with metastatic renal cell carcinoma can benefit from having metastatic lesions removed, especially if it renders them disease-free. But for the sake of discussion of just cytoreductive nephrectomy, there's no doubt that it's beneficial in most patients with good performance status. So we're talking about ECOG performance status of 0 and 1, whose tumors can be removed. What determines removability is a question that I think we've learned over the last decade and a half. And to me, it's not, in my opinion, it's not the size of the tumor that determines resectability, because a lot of people say, oh, this tumor is too big to resect. In my opinion, it's not the size of the tumor, it's the amount of lymphadenopathy around the renal hilum. For instance, in my opinion, when there's a large amount of lymphadenopathy around the renal artery and renal vein, that's what can make surgical resection very difficult. As opposed to a big tumor with, say, even a renal vein thrombus or a vena cava thrombus without a lot of lymphadenopathy and without a lot of heavy, bulky metastatic disease, we're definitely aiming to remove that kidney before we start systemic therapy.